listening to the Pharmacy Podcast Network.
At RxSafe, we believe in improving patient health by challenging conventional wisdom, upending the status quo, and transforming the retail pharmacy industry. Our innovative technology solutions are designed to accelerate your pharmacy's success and change the way you do business. We develop long-term partnerships with pharmacies and other industry innovators to help attract new customers, create additional revenue streams, and transform the traditional pharmacy model. Become the adherence packaging leader in your community and practice at the top of your pharmacy license. Get started today. Visit RxSafe.com. That's RxSafe.com to learn more.
Hey there, welcome to today's webinar. I'm really excited about this. We're going to talk about defeating DIR fees with long-term care at home. And before we get into this wonderful panel, which I'm so excited in the gathering of this, I want to bring something up to our listeners. If you are watching this through YouTube, through RxSafe, through their blog, you'll be able to see the screen that reads in big titled letters for this article from the New York Times. It says, desperate families search for affordable home care. Today is so relevant to what's happening in our nation. The nation is facing a severe shortage of aides, and high costs are prevalent. People are trying to keep aged loved ones at home, often cobbling together patchwork of family and friendships in order to see these people get the care that they need. And what do I think? Community pharmacy. Enter independent community pharmacy at a time that you're needed more than ever. And what's about to happen with the explosion of our baby boomers continuing to grow? They say there will be over 12,000 every month in the year of 2024 that will be added to that age bracket. And the consumption of home care services is going to be so needed. Every day we know community pharmacies are facing challenges right now, especially with relying on dispensing fees alone. It's really not a business model that you're going to be able to grow as we saw it sustainable 10, 20 years ago. And those dispensing fees, it's just not enough as a community pharmacy owner. Today's pharmacies, we need to diversify incomes. Think about cash-based businesses, profitable business streams and income streams. You think of the diversification. We've heard about testing. We've heard about point of care. But today we're going to dig a lot deeper into home care services on top of the tools that come with that as a pharmacy. Adherence packaging, being able to guide people to stay on their meds, increasing adherence. I'm excited to introduce today's panelists. We want to welcome Paul Shelton from Pharma Complete, as well as Rana Hauser, no stranger to these panel discussions with the NCPA. Susan Rodas is back from GeriMed. We're so appreciative of GeriMed being here. Debbie Marcello with Happier at Home, the host of the Happier at Home PRN podcast on the Pharmacy Podcast Network, as well as pharmacy owner Thomas McDowell, owner of McDowell's Pharmacy, as well as a Happier at Home franchise, so that we can talk about things that are actually working and not just conceptual. I'm so excited about this. We know that the first quarter of 2024 is going to be a little extra stressful on our independent pharmacy owners with a new change in system at point of sale happening with DIR fees, 2023 plus the new transparent DIR fees that occur in when that money is extracted from your whole revenue cycle. And this means pharmacies are going to be paying significantly higher DIR fees than normal for that first part of 2024 until all of the retroactive fees have been paid. This will have a significant impact on cash flow. Before we get started, welcome back, Debbie. It's so good to see you here, and thank you so much for all the content this year on Happier at Home PRN.
Oh, thank you so much, Todd. And I think that what we're presenting to everyone is vital to their survival of our listeners that are pharmacy owners. And I'm so happy that you're always on the cutting edge and bringing everyone information. So I'm excited to be a part of this panel. Thank you.
Thank you. Rana, it's so good to see you again and you being part of this panel. It's like I said, I think we have a packed panel today, and I appreciate you being here.
Thanks, Todd. Happy to be here and talk about what we're doing to help pharmacies be more engaged in LTC at home, and also can speak a little bit to what we're doing to gauge the impact of the DIR hangover that you mentioned earlier. So happy to be here today. Thank you.
Absolutely. Susan, welcome back. Thank you. And a special thanks to GeriMed for all of the support that you've given us in multitudes of ideas about how to navigate this. But I want to welcome you.
Thank you very much, Todd. I appreciate that and look forward to the conversation.
Paul, it's wonderful to have you here. I enjoyed the recording that you did at the NCPA with Framework LTC, Framework Focus. I have listened to that conversation several times because I've been taking notes for some of the planning that we're doing, expansion of long-term care pharmacy services. So I really appreciate you being here.
Absolutely happy to, Todd. Thank you for having me.
And the guinea pig of the room, and who we test everything when it comes to pharmacy ownership, it's Dr. Thomas McDowell. It's so thrilling to have you here because you're really where the rubber meets the road, Thomas.
Thank you, Todd. I'm glad to be here. I'm working with most of the folks on this panel, so you got a great group and excited to talk about today's topic.
We're going to kick this off. And like I said, rubber meets the road with a pharmacy owner. This question and just the kickoff is going to open up with Thomas. And that is, what do you see happening in the industry right now, Thomas? And why are we talking about, why is it so important? Not only the headline of the New York Times that screams to the nation that we are desperate for services and home care, but we also know what community pharmacies are going through and the privately owned community pharmacies are going through in 2024. So expand upon that and let us know what you see happening right now.
Well, there's a lot going on just in healthcare in general, but in community pharmacy, like you touched on, the change in DIR legislation that we've known about for a little bit now and have been kind of looking forward to, but kind of dreading at the same time. It's provides a lot of transparency at point of sale now in 2024, which is exciting. But like you mentioned, the clawbacks will still be happening from Q4 2023. They'll still be clawing back fees in early 24 from the low, after DIR fee payment. So that'll create a cash flow crunch at least for several months, and that was something that wasn't really thought about when the legislation was put together, I guess, or was left out. But it's still a good move, I feel like, as far as transparency goes. But we just need to be thinking about other ways we can position ourselves to provide services and find revenue beyond the dispensing, because the dispensing is not great on the retail side. And so we're always looking for different ways to adapt and seeing where we're going in this country as far as baby boomers aging and needing more services, home care, pharmacy, long-term care at home pharmacy services. You can really start connecting some dots to take care of patients in your local community and keep them as a part of your family versus them getting sucked up into the healthcare system and with all of these other major players that really have a hard time taking good care of patients. I believe healthcare is best locally, and so we're positioning ourselves to try to keep taking care of patients and be profitable doing it.
Excellent. Rana, I don't know if it was 10 years ago. We'll have to dig into the NCPA archives, but I remember when the NCPA at one of your national events, one of the annuals, you announced long-term care by NCPA, and it became kind of a division within NCPA so that we could do things that were specific to those community pharmacies that were growing and balancing, obviously, their community pharmacy services, but also assisted living, which was expanding outside of their communities. As these pharmacies actually age with their own communities and populations over and over again, they're part of the community. But what insight that now we're seeing that this isn't something that's just about staging anymore. It's literal. I mean, we're seeing that long-term care at home now is a real play. So talk to us about what's happening in the industry, what you're seeing happening, preparation for things that are cash-based that give us an opportunity to thrive in 2024 as a community pharmacy owner.
Yeah, absolutely. Happy to, Todd. And as you mentioned, NCPA's long-term care division is alive and well. We see long-term care services provided by independent pharmacies as vital. We believe that there's remaining huge growth opportunity for independent pharmacies to be more engaged in providing long-term care services. And we try to make those connections for our members, because oftentimes our members may not even realize that they are truly providing long-term care services. So we want to make sure that members realize the value of long-term care, and they're in the business as much as they can be to help with other threats. Thomas mentioned the hangover is coming. The DIR clawbacks from 2023 will come due in 24 with lower payments at point of sale. And he's absolutely right. We supported at NCPA and advocated for these changes to bring our members more clarity and more transparency in their drug price negotiations and their contract talks with the PBMs. But we always knew that this period to get through the first half, first 3 quarters even of next year is going to be very difficult. So we've been doing all we can to educate our members. We have an entire webpage at NCPA totally dedicated to the hangover and what everyone can be doing to prepare for it. And when I say that we are gauging these impacts, we're working with industry partners come the new year to see how severe this is. And believe me, we'll be asking for both administrative through CMS and the administration and congressional interaction if needed. So all that said, I think a bright spot in our industry right now is LTC at home and what we've been able to accomplish with formation of the Alliance and all the partners really working together to advocate to CMS to have plans recognize these services. I can talk here in a few minutes more about the Alliance and what we're working towards, but I completely agree with you. LTC at home is a wonderful opportunity and one that more independents need to be aware of and be thinking of providing.
Paul, you saturate yourself with data. You're extracting data from the pure long-term care pharmacy, but you're also mixing that in with community and what is the evolution of what that means for profitability for community pharmacies. So as someone that is an analyst and deep into that, how do you think pharmacies should be preparing for DIR fee transition, the period between 2023, 2024?
No, that's a great question. I think to address the first statement there, which, we look at data, it's amazing the number of times we've done long-term care at home assessments for pharmacies and looked at the current pharmacy payer groups that are paying either continue to pay retail rates with no DIR fee impact or retail rates with no DIR impact plus the dispensing fee, and see how much of an impact this can make to a standard community pharmacy. I mean, at this point, I think we've done just over 150 of these assessments for pharmacies. And in one case, we found a pharmacy that it didn't make sense to explore. And that's because they were only doing 40 prescriptions a day. And the question there was, okay, you either need to grow your pharmacy or close your pharmacy. It's not big enough to be viable in and of itself. But literally every other pharmacy we've done an evaluation for, even at a conversion of as low as 15% of their eligible patient population, it's made sense. It's been very additive. I mean, one of our customers moved 71 patients into long-term care at home from their community PSCO to their long-term care PSCO and had an immediate $10,000 a month impact on DIR fees. I mean, that's profound for a community pharmacy. That's the cost of roughly the full cost of another pharmacist to provide additional care in the community and to do things differently. So really seeing the data proving out that long-term care at home is an extraordinarily viable opportunity to avoid that DIR fee hangover. But at this point, if you're not already doing it, it's a little bit too late. You're not able to turn that corner in the next, 19 days, because I mean, it's where we are. We're 19 days out from 2024, which is terrifying in and of itself. But at this point, it's looking at other services, other things you can do. Start the process to get set up as a long-term care at home pharmacy. Get your taxonomy set with your dual taxonomy. Get your combo shop set up if you haven't done that already. But that process, best case scenario, takes 90 to 120 days. So what can you do near term? We had the opportunity to sit down with about 18 pharmacy owners while we were at NCPA this year at a Flip the Pharmacy conversation, and got to ask questions about, hey, what are you doing? And it was amazing, some of the things, the cash-based solutions that the pharmacies were doing. They're doing travel clinics. It's not just the vaccine, but all the supporting products that go along with it. These are for huge vaccination clinics, and it may not be a large volume on any given day, but each patient's coming in and getting a consultation of what they need. They're purchasing ancillary supplies to support their travel. Working in non-PBM based compounding. So you're doing your pet meds where it's amazing to me how some of our patients will say, well, I'm not paying $20 for my insulin this month, but I'll pay $70 for Fluffy's medication. It's amazing. And so finding some of those things that are more cash-based solution, engaging with partners who have little atypical concepts. Maybe that's a concierge medicine practice within your existing pharmacy space. Again, none of these are quick fixes, but they're things that you can set yourself up for success as you're going into Q1 for 2024.
Excellent. Thank you, Paul. Debbie, you couldn't have come at the right time when you came. I don't know if all this happening. But here you are, with a turnkey program to help community pharmacies implement services that their communities need. As I said, New York Times is now reporting on this desperate search for home care services. Enter 19,000 community pharmacies throughout the country. And here we go with Happier at Home. So what a wonderful serendipitous opportunity to engage and insert yourself into one of my favorite parts of the pharmacy profession, which is community pharmacy.
Yes. The statistics, as Paul was talking about, show that globally, the population of the elderly is going from 90.2 million in 2020 to 130.8 million by 2045. So as the elderly population is growing, we see that the number of home care agencies is decreasing. And why is this decreasing? It's because there are cuts in reimbursements from insurance companies. And in addition, larger retailers like CVS, insurers themselves, and other large companies see the writing on the wall, and they're strategizing for their survival and to get their piece of the pie. So what I'm proposing for our community pharmacies is that this is your opportunity. You are the one-stop shop and the hub for your community. You have your reputation. So have that help you carry your company into growth within the next few years. This is an opportunity for you to be able to get a cash-based source of revenue by expanding into home care services. And at the same time, as our other panelists are talking about, using and utilizing the LTC at home with the pharmacy services, they go hand in hand. You develop happier at home patients, and you can serve those patients at your LTC at home services. And as Paul was saying, with these other potential sources of revenue, travel clinics, if you also want to be able to do point of care testing for your patients in their home. So there's a lot of synergies between our home care patients through Happier at Home and the independent pharmacies. It makes too much sense to not give it a second look and really help you to be able to grow and strategize in 2024.
Thank you so much. That's a great table setter for us to move to Susan and dig into what GeriMed has been formulating for years through special contracts that you've been doing I want to ask a simple question, and that is the eligibility of this in order for our community pharmacies to know, hey, number one, I should be calling GeriMed just to understand the contracting and things like that. But number two, let's talk about patients that qualify. Expand upon that, Susan, and let us know what you've shared with your membership.
So that's a really great question, because not every patient that's a Medicare patient qualifies to receive the extra benefits of having long-term care pharmacy at home. It is people out there that are a big deal is someone who is unable to leave their home without assistance. So someone who's not driving anymore. It doesn't mean they can't be mobile, but they can't be doing things like going to the pharmacy and getting their own prescriptions. They may need their son or daughter or husband or wife to assist them with that. So that's probably the biggest thing out there to look at, as well as ADLs, which is activities of daily living. They need to be needing help with things like toileting, dressing, taking a shower, eating. And then IADLs, which is a special part that I think really brings pharmacy to fruition, because medication administration is one of those. And if they have an issue with remembering to take their meds at the right time, taking the right meds at the right time, setting up their medication correctly to take them correctly, any of those things would qualify them to say they have an issue with medication administration. It also includes things like banking. Are they able to do their own banking? Are they able to clean their own house? Are they able to go and cook a meal for themselves? All of those things are important. So if you have two or more of those, then you are under the qualifications. And then maintenance medications. Do you have 6 or more drugs of maintenance medications you're taking on a daily basis? Some of you may have 1 or 2 and they really don't need assistance with their medication because they're not taking very many, would not qualify. And then the last thing out there is 3 or more chronic conditions, medical conditions. So do they need to have those conditions? Are they listed? I mean, people like COPD, diabetes, hypertension, congestive heart failure, all of those type of things. Do they have 3 or more of those disease states that they have as a chronic condition they're receiving medications for? So all of those things kind of tied up together. It actually is set up as an attestation that the pharmacy can keep at the pharmacy there for each patient that they're taking care of. So if somebody came and audited them and said, hey, this person really doesn't qualify, they can prove that the reason why they're on the program. And I like to term it as more of a need than a convenience. I always talk about, Joe Smith, who lives in Florida and drives around in a golf cart every day playing his golf game. And he just doesn't feel like going to a local community pharmacy to pick up his medications. He would not qualify because he has the ability to go to a pharmacy and pick up his medications, and he's driving around in a golf cart. So he's definitely not someone who would be subject to this. But you're talking about a lot of people out there, especially people who have, mild to moderate dementia, who are in their home and just cannot do these things on their own, and have a family member helping them on a daily basis, or have somebody else coming in to service them, somebody like a Happier at Home that is coming in to help them with doing things, they would qualify. And to me, the biggest thing is a pharmacy that's a community pharmacy is really someone who can attack this from a variety of sources. They're really the ones who are seeing what's going on with that patient. They can pick up the phone and call Meals on Wheels if the person can't get, enough meals. They have no family members around to take care of them. They can make those phone calls and connect that and have a coordination of care to make sure that that person is able to stay in their home, because it's not just the medications. The medications are super important. To me, if you can make sure people are taking the right drugs, you're going to have a lot less people going to the hospital or to a nursing home because they're taking their medication correctly. And that's what we're trying to do. We're trying to save the system money. We're trying to save Medicare money, tax dollar money, but provide great services so these people can have a better quality of life.
Thank you. Thank you, Susan. That's terrific. And that brought us full circle. That brought us back to Thomas. Thomas, it's been layering over the years. Your organization, your pharmacy has been very keen and paying attention to what the community is going through. You kind of grown with that community. And you've invested in technology and processes and marketing and adherence packaging. And now you've come to a point where you've launched your franchise, Happier at Home, as a home care organization within your community. That's the layering that we're talking about, to get away from always being held hostage to a dispensing fee per se, and really kind of building out the services that you've done as a pharmacy owner. Talk to our pharmacy owners listening in right now about some of that layering, about delivery, about central fill, and how you've used filling for times, syncing medications, and adherence, and of course adherence packaging, and it prepared you for where you are today with long-term care at home pharmacy services.
Well, it definitely helped that we built the infrastructure, over several years. We have an RxSafe rapid pack strip pouch packaging robot that we purchased right in the middle of the pandemic. Really more of just a way to scale up our adherence packaging. That was before I had, even heard of long-term care at home at that point. So we were just trying to get more fills, and keep patients more adherent, have a positive effect on our star ratings. And we really grew our adherence packaging program. We developed a delivery model that was very efficient, got a lot of help along the way, asked a lot of questions. And so that really made it a lot easier to transition into the long-term care at home space, because we had that model, and we've been doing long-term care services for skilled nursing facilities for 30 years. And so that makes it easier, but it's still a fairly easy entry. It's just understanding it, and there's just a lot more awareness around it now that the folks on this panel are bringing to community pharmacy owners, which is great, because there's a great opportunity there. And so we've transitioned from that over into long-term care at home, and that's allowed us to have enhanced reimbursement and truly be paid more fairly for the work that we're doing for these patients, the adherence packaging, the delivery, the regimen reviews, the accessibility, and the long-term care type of services, and keeping those patients healthy and at home, and keeping them out of the hospital, which is a big advantage to the payers and to the healthcare system in general. And we saw an opportunity to take that a step further and complement that with Happier at Home. These patients that are receiving long-term care at home services are also patients, when we're talking about needing help with ADLs, that's what we do on the Happier at Home side. If they're needing help with the IADLs or the ADLs, they're a good candidate for Happier at Home services. And so the two, revenue streams, two programs really complement each other, and we can help those patients not only receive their medications in an efficient and timely manner, but we can, have a caregiver go and remind them to take their medication. That's kind of the last piece that we haven't been able to do is make sure they actually take every single dose at the right time. Even if you put the time and date on the pouch, it still doesn't always happen. And so it's just been a progression, just keeping my eyes open at all times to see how we can still, be a factor and add value. I always want to add value to our patients. If we're just dispensing and doing the same old thing and letting everybody pass us by, then I'm not doing my job to add value to our community. So that's kind of how we got to where we are.
Excellent. I like how you built that out in chronological process order, and it makes sense. And you're well prepared for what's coming, and that's extremely important. Rana, you mentioned something with your opening that I want to come back to, and that is the Alliance for LTC Pharmacy at Home. Talk to us a little bit about that and what you mentioned, and how that will help to support this ongoing initiative and the coupling of NCPA's power, as well as the ASCP and the SCPC, which is really all of these organizations that are really helping to navigate the very specific services that are within senior care.
Absolutely. I'm happy to. NCPA, with our long-term care division, has for several years had payment for LTC at home as our top priority. And we were very happy when, going on about 2 years ago now, CMS at least put out a memo to plans that CMS recognizes that these services exist, right? They recognize there are LTC pharmacies providing care to Part D patients, and some of those patients may be located in a home setting. So it was at least a good entree, and we feel like it was a big win to get CMS to recognize these services, right? Moving a giant federal bureaucracy is not easy. So we were pleased that that happened, but we know there has to be more, right? So we joined forces with our partners in the long-term care pharmacy space. That's the American Society of Consultant Pharmacists and the Senior Care Pharmacy Coalition. And we said, hey guys, we really need to have a formal, structured effort to define what LTC at home is, what are the services the pharmacies are able to provide, who are the patients eligible, to Susan's earlier point, and what are the savings associated with these services, and what's the marketplace look like in the future? You know, the number of patients eligible for these services or eligible for, long-term care, needing long-term care, are supposed to triple, right? And the number of beds available to take care of them is going to stay stagnant. So we felt that the time was right. So about a year and a half ago, we formed the Alliance for LTC at Home. We have a website, so please check it out. It's pharmacyathome.org. We outline who we are and what we're hoping to accomplish. And I will say to date, there's been a lot of successful efforts that have come out of the Alliance, educating key members of Congress and key committees on what we're trying to achieve. But our number one goal still remains to get CMS to put forth a regulation that would not only recognize these services, but require payment for these services from Part D plans. And, under the same general constructs that LTC pharmacies are paid today for caring for those patients in skilled and other facilities, we want to add on another layer of patients eligible, which would be at-home patients, and do it under CMS current authority. So we've had a lot of good dialogue with CMS, and we're going to continue to do so, and get them as an agency, hopefully, to move to mandate plan payment for these services.
All right, I do have a follow-up question, and that is, and this may be for either you or I would assume Susan, and that is the documentation of patient care, which is such an important part of bringing that data back to our payers, CMS, for example. So how do you document patient care in long-term care at home pharmacy setting? Like I said, you, Susan or Rana, whoever wants to take it.
I'll let Susan take that. She talked about attestation earlier, and I know Susan's great to expand on that.
Yeah, so if you're remember everything, nothing happens unless you document it. So if you don't document that you did something or that you interacted with somebody, then it didn't happen. And that's a kind of a tenet in healthcare in general. You need to put something down someplace that you actually accomplished something. I mean, if you don't have a prescription for a drug and someone audits you, you're going to get that money taken away because you don't have a prescription. So it's just like that. It's the same type of thing. You have to have that documentation that you picked up the phone and you called. If Mrs. Jones has 3 doctors that she sees, you need to call all of them. You need to make sure that everything's the same that it was the month before. And if there's changes, you need to document what those are. You need to document that you talked to the caregiver. Thomas was talking about that, we still don't have a methodology to make sure somebody took their medications. You need to talk to the caregiver and make sure they're giving the medications at the right time if they need that help, and make sure that that's happening. So any of that stuff that you're doing, we'll document that. And then documenting, if Mrs. Jones last year went to the hospital 4 times and you, through your services that you're doing and coordinating their care, now this year they only went to the hospital once, that's a significant decrease in costs. And you need to show that. That's probably one of the biggest things that we've been asked is tell us how this saves money for the Medicare system. And while there's some studies out there and it's kind of a no-brainer, I mean, to me, if you take the right medication and 30% of people that are readmitted to the hospital is due to something going on with their medication, and you can prevent that from happening, it's kind of a no-brainer, but they want data. So any data you can collect, we work with several pharmacies who have collected data out there and shown that to plans who are very impressed with that. They're not impressed enough to change what they're doing on payment, but they are impressed with it. I think that's a super important piece of what you're doing. And that demonstrates the clinical abilities of the pharmacist. I think, I've been at a pharmacy school for a long time, and we've always been talking about clinical pharmacists doing the work that they need to do. And we need to do it so we can show that it's worthwhile to pay for these extra services that you're doing.
Paul, I understand it was initially long-term care pharmacy that you really started digging deep into, and your clients started out there. But now it's the ebb and flow of our macroeconomics of senior care throughout the country is kind of bringing those two closer together. Community.
Absolutely.
What can you share with the listeners that you've learned in kind of the rising of this opportunity and something that I know that you're personally excited about?
Really, I mean, we see in most community pharmacies the opportunity to participate in long-term care at home because they're already doing it, right? They're already serving those patients. I think of my chief of staff's dad, who's been served by our local community pharmacy for the last 6 years, and the fight we had with him to get him to convert over to compliance packaging, and he's a prime example of someone who needs long-term care at home. He can't safely drive himself away from the house. Her mom has to take him to all of his doctor's appointments, take him to the pharmacy. He needs support with about 3 activities of daily living. And, he swears he's a healthy guy. He's like, I don't need this. Prior to receiving compliance packaging, he was in the hospital every single month for 6 months. And we finally convinced him to take the compliance packaging in part because my chief of staff articulated to him, said, "Dad, this is a benefit that's paid for by your insurance." He happened to be in one of the plans that does pay a little bit more for long-term care at home. And so she was able to convince him that this is something your insurance is already paying for. Why don't you take advantage of it? And we were able to get him to convert. The pharmacy does exactly what Susan said. They document every single month that no changes have happened, that he meets the criteria. They do the attestation form once a year for him. But in the 6 months since he's had compliance packaging, he's had 1 hospitalization. I mean, these are not small hospitalizations. He's 27 medications, insulin dependent diabetic. And this is, for me, this is a profoundly personal example of why what we're doing is making a difference. And every pharmacy we talk to, within 15, 20 minutes of them understanding what long-term care at home is, you can see kind of the technicians and the pharmacists start thinking, oh, wait, I know we've got this patient and that patient and this patient and that group of patients over there. They don't, in many cases, understand that group homes can be institutional long-term care. So they don't understand that some group homes qualify for assisted living levels of reimbursement. So in many cases, it's a lack of understanding in the community pharmacy that they are servicing long-term care patients already. And to your point, Todd, it's like, we grew up in long-term, my organization grew up in long-term care. That was where our happy place was. We were there all the time. And as we're seeing these two kind of worlds collide into long-term care and long-term care at home, it's really been eye-opening how many community pharmacies are already doing this work. They're just not getting compensated for it. And really that's the challenge is, unless you know to set your pharmacy up under that combo shop dual taxonomy and bill correctly for those patients, whether they're an assisted living facility patient, a group home patient, or even some of these. I was talking to a pharmacy last week, doing 100 skilled nursing patients and billing it through their retail PSAO, and you just are like, my man, we got to figure out how to fix this, because you're leaving thousands of dollars on the table every month because you're not getting paid for the work you're doing. And so really where we've had a lot of success and frankly a lot of fun this year is helping pharmacies understand what this can be and how it can change the fundamental, bottom line of their business in a world where we've seen gross margin in community pharmacy compressed from 25% on average nationally down to when we see some of the programs are around the 19 to 21% gross margin. And then we see a shop that's doing reasonable long-term care at home volume, and that number's back up at 26, 27% again, because they're getting compensated for the work they're doing. That's putting community pharmacy back into a healthier position so that we can continue to get them through 24 and into that next phase of what is community pharmacy going to be.
Debbie, I want to shift the gear back to the implementation phase and being able to expand home care. Thomas made a really good point that he had infrastructure to do so. The offering that you present, the services that you present to our community pharmacies have become more and more focused the more that you've done this, because you're actually starting to add things. But talk to us about implementation. Talk about we're doing this webinar in December. We know the new year's coming. What's the timing? I know that you've answered this. I've asked you this question before. You said sometimes it's different for different pharmacies, but on average, how long does it take us to roll this out so that it dovetails into the services that Thomas was prepared for?
So, as I said, it does vary, but it is also based upon the owner. So the owner, if they're following our due diligence schedule, so they're learning about us, understanding what services they would be providing, which would include not only help with those ADLs and IADLs, but also acting as a care advocate. So going to those doctor's appointments, making sure they're medication compliant, and understanding that their loved one is actually following the medical regimen that the doctors prescribed. And then also where the pharmacy may leave off, as Thomas was saying, with delivering those medications, not knowing that that patient is taking them. There are different medication management solutions. So management and making sure they're staying compliant. So understanding what the business is, the process of learning about Happier at Home and starting up a Happier at Home is usually about 3 months. However, each state may have licensure requirements. You go to Alabama, they have no licensure requirements for a home care company. North Carolina has some that are different from California, but we help step through all of those on a one-to-one basis with the consulting. So we're looking at anywhere from 3 months startup to about 6 months, but usually we somewhere right in between is a sweet spot to get going. And I know our one franchisee in Iowa, she specifically started this so she could have that cash-based source of payment and make up for losses, where our profit margin is usually about 35%. So I heard from her probably about a month ago, and she said, you know what, it's not only, it's doing what I wanted it to do, earning a revenue source that is actually keeping us afloat right now. And she said she just wished she did it sooner. So I think that there's always reasons for not starting a new venture, but there's more reasons for not getting started immediately to help strategize and grow your business and survive, honestly.
More than survive, to thrive, and have pharmacies that can do more. What ends up happening, independents end up giving back to their communities in so many different ways, creating jobs and little league support and local schools and scholarships, just so many things that can come out of that. I want to turn back to Thomas and just say you're now a well-oiled machine. You've fused community pharmacy services with adherence packaging, RxSafe technology. You've aligned the Happier at Home ability to service more, to do more in the home care realm. Talk to our pharmacy owners about marketing those services to get the messaging out so that the community knows, hey, McDowell's now has a pharmacy service that gives home care services to us as well.
Yeah, you can have all of the technology and the services, but if you don't tell anybody about it, they'll never know. So we try to tell everybody about it every chance we get. I talk about it when I'm out networking and doing marketing and sales, and we've tried to blend the services together so that they're very complementary and cohesive. So people already know about our pharmacies, and that helps us with talking about Happier at Home services, because we have good relationships with our community, our patients, our providers in the area. And so, folks are looking for a home care agency they can trust. So that makes that a lot more seamless, and there's already a relationship there versus starting from scratch. We have a captive audience of patients coming in and out of our doors every day. So, taking advantage of the foot traffic in your pharmacy to leverage other services, which is always important. We have the patients coming in your, most pharmacies do, unless they're a startup or very low volume. You have enough patients to be profitable. It's just how are you going to be profitable and add value to them and let them know about what you're doing. So we're active on social media, and we also get out into the community and talk to folks and build relationships. That's what's worked for us, and I think that's what it's all about, making sure that if you're an owner that you try to get out from behind the bench, working on the pharmacy as much as possible versus working in the pharmacy or letting the pharmacy run you. It's very hard to grow your business or grow new services if you can't get out from behind the bench.
Yep. Excellent. I want to ask the question. I'm thinking, Susan, you probably come across this with your membership through GeriMed. If a pharmacy owner comes to you and says, now, how do I actually get started in building my long-term care at home program? How does a pharmacy owner take the steps? They may not have done what Thomas has done. As a matter of fact, we know community pharmacy owners, everybody does it a little bit differently, but there's got to be this blueprint that you've shared with other members.
Yeah, I mean, I think it's important to know that you don't want to necessarily join a group like ours until you really have enough basis for patients that you're taking care of, because it financially doesn't make sense to do that. You have costs to sign up with a network, costs to sign up with certain plans. So we kind of target a number of 50 patients to really make it financially worthwhile for you to join a network like GeriMed. And you're going to get cost savings both on brand manufactured drugs, as well as on better reimbursement from the PBMs for those patients. So you have two things to look at, but you really need that number of patients, and you need to make sure that you have the number of patients in the plans that are going to make a benefit for you. So there's a couple of plans that don't do that. So you got to be careful when you're coming over and talking to us that you have the right mix there. And definitely people that we have on staff can help you with making sure that you're doing this at the right time. And a lot of times we'll tell you, go back and keep working on this and get a few more patients before you actually sign up for it. And then you will be benefiting yourself all the way around. You're not going to spend money for nothing, because you do want to make sure that you can do this. We've had people who will come in and, have 25 patients and then they can't do it anymore, and they've spent a bunch of money for nothing. So we highly recommend that they really take a look at how many people they're taking care of and how many of those people that are walking in their door would qualify for it. And something I want to make sure of is that you understand what you have to do to be a pharmacy that can do this. You have to follow the criteria from CMS, the list of 10, without doing e-kits or e-logs, but everything else you really have to do. And the biggest three are going to be compliance packaging, 24-hour accessibility, 24/7 accessibility to a pharmacist, and delivery of the drug. So those three things have to happen. And I'm going to say compliance packaging about 15 times now, because that's when people come back and go, compliance packaging, do we have to do that? And it's like, yes, you have to do compliance packaging. So we're not talking about insulin or injectables. We're not talking about liquids. We're not talking about ophthalmics. We're talking oral solid medications that you are supposed to be doing that. You're really not going to be doing the beyond oral solids. And, people asking that question. Yes, if you get an antibiotic, you should put it in some special packaging. Yes, if you have a PRN, you should put it in special packaging. All of it should be done that way, because that's a big part of the service and what CMS requires for you to be counted as a long-term care pharmacy, period.
Susan, if I can, I'd like to interject too. The IV and custom compounded medications is another one that a lot of pharmacies miss on when they set up, because that's one of the 10 criteria. It's actually 2 of the 10 criteria. And we find a lot of pharmacies don't have access to IV. And there's a PBM right now that's actually doing an attestation for pharmacies to say, I can meet these 10 criteria. If you don't have a contract in place to be able to provide IV services, we strongly recommend setting that in place. There's a bunch of different organizations you can outsource that to. Your local hospital, if they've got a IV capable pharmacy, definitely get that contract in place. You'll probably never need it if you're just doing long-term care at home, but it is one of the requirements for CMS's guidelines. And again, Susan is completely accurate on compliance packaging as well. We get that question all the time.
Yes, and going back to the IVs and the compounding, it's a capability of doing it. It's not that
Exactly.
you're doing it today in your pharmacy, and I think people get confused about that. It's the capability of doing it. So if you have a contract to subcontract it, that's literally in the manual with CMS. It says in there that you can subcontract it. So don't let that scare you to say, "Oh my gosh, I don't have a hood in my pharmacy. I'm not following all these guidelines from USP. I can't do this." Yes, you can, as long as you have that separate contract. And we can help with that too. That's not a problem.
And I know Susan mentioned 50 patients. I mean, if you look at most pharmacies that have been paying attention to anything that NCPA has said over the last 10 years around medication synchronization, compliance packaging, and that process, if you have a MedSync program and you've got a compliance packaging program, and you've been doing this since, Rana, when was the first time you guys started talking about this at the national conference every year? It was like, what, 2012, 13, somewhere in there?
Right.
Like MedSync was 2010, exactly. That proactive approach to pharmacy. So when you synchronize your patients, that's a proactive approach to pharmacy versus a reactive approach to pharmacy. Inside that, if you have 400 patients that are on MedSync, you can easily find, in our experience, you can easily find 50 to 100 patients that will qualify for long-term care at home, that will qualify for increased reimbursement. And it makes sense. If you don't have that 400, start small. Find other, if you already have a compliance packaging program, look in that, go through those patients and see who might potentially meet those criteria. Look for those low-hanging fruit opportunities, group homes, home healthcare agencies. If you have a Happier at Home franchise, cool. That's literally just a ball of patients that are probably 95% of those are going to qualify for you. So it's a great opportunity to plug into. But just because you haven't started this process, it's not as hard as it can seem. I mean, it can feel very overwhelming when you're talking about it's a 90-day paperwork process or 120-day paperwork process, but just identify patients quickly, look at the bins and PCNs that apply, look at your patient population, and you can probably identify those without too much effort. The other thing is ask patients. It's amazing the number of times that I go into a pharmacy and they say, we've got this great compliance packaging machine behind us. I've got my Rapid Pack and nobody wants it. And I ask, well, how many people have you asked? None. Okay, so every time someone walks in with more than 5 medications, ask them if they want you to put it in packaging for them. And that gets that ball rolling to help find and identify additional patients for you.
I'd also like to mention that as far as the qualifying factors go in documentation, Susan obviously is so right about documentation. And as a registered nurse, that's always a mantra. If you don't document it, it's not done. Within our systems for Happier at Home, your caregivers have a way to list out what types of services they provided with each visit. So Thomas may put in what their care plan is for each visit, and it would include those activities. And when the caregiver clocks out by telephony, that caregiver will call the number to the scheduling system, and it will ask them, did you complete this activity? Yes or no? So we have the documentation for each visit that these activities of daily living or IADLs are being completed as well.
I cannot help it. I always revert back to where I started in pharmacy, and it's the pharmacy management system. It's that pharmacy software. And as everyone's talking, and I'm watching our participants in the webinar increase. I'm thinking of people listening to this in a podcast. That $1 million head scratch question is, can I extract a report from my pharmacy management system that could quickly identify, am I a good candidate for long-term care at home or am I not? Now, there are a lot of intelligent, very well-to-do community pharmacies out there that are prospering and doing well. They're probably already down the road. Then there's a mixture of those that are on the fence that are like, I want to get into this. Obviously, there's money to be made. There's services that are desperately needed for my communities, but let me know how to run a report to actually assess. Is it 2 ADLs? Is there 3 chronic conditions? Limited mobility? Do they take more than 6 medications? Paul, I can't help but to think of you because you've kind of operated this a while. What report is that? I mean, there's lots of PMS systems out there, but how would we come up with that formula to say, hey, am I a candidate for this or am I not a candidate for this?
At a high level, pull patient claims data for the last 90 days with unique patient identifier on it, and then sort it by BIN and PCN. You're looking for ESI and Optum patients to start with that are on 6 or more medications. You can probably look at the 6 medications and determine if they've got 3 chronic conditions. And then that's a good starting point. It's not perfect by any means, but it'll at least give you a group of patients to address. There are some tools available out in the market that you can utilize to get that done quickly. There's a couple of different organizations that can help you sort that. Your prescription management platform should have a claims history. It's literally just a claims history report you're looking for.
Thomas, let's talk about referral sources. You're in the thick of it. You have all the pieces, like we said, moving forward, ready to jump in and hammer out a very successful and thriving 2024. Talk to me about identifying good referral sources and what you're going to target in the new year.
So, letting providers know about the long-term care at home program. They're going to love the extra care and services and the quality that you're bringing with the adherence package and the delivery, the accessibility, and the whole suite of long-term care specific services. They're going to know their patients are being taken care of. So they're going to be talking about you, home health, hospice, and hospital systems, nursing homes, and a lot of the same, on the Happier Home side, when we're doing marketing and sales to referral sources, a lot of times they're, one and the same with the pharmacy and the home care side. So we can really talk about the whole suite of senior care services that we're offering, which makes it a lot easier because they just complement each other so well. So, but we're always really trying to let the providers know, the prescribers, especially on the long-term care at home side. But, identifying those patients within your own 4 walls is the easiest way to start, because like Paul's mentioned and Susan and you have patients that you're providing these services for. You just need to dot some I's, cross some T's, and make it a little more formal and follow the guidelines to do it the right way. And so it's easiest to just start doing some research and digging and find out who qualifies for long-term care at home within your pharmacy. So that's what we did to start with, and then we started marketing and letting folks in other areas know what we're doing.
So Debbie, you have a blueprint for taking a community pharmacy from pure pharmacy play deeper into home care. And you have coached so many pharmacy owners to implement your strategy. Let's go back to that same question. From your perspective, what are you coaching your members, your new franchise owners to do to properly put the message out in the community to physicians, to care people, to churches? What are you talking about with them to market these services?
Well, Thomas is correct that so many of the referral sources are going to be synergistically aligned. So with our training, what we talk about are the pillars of marketing. So Our pharmacy owners have developed these relationships, especially if they're providing LTC in facilities. So you may have relationships with the transitional care, case managers, physicians' offices, discharge planners. Those are a great focus because, as you know, if a patient is discharged and they return within 30 days to the emergency department or are readmitted, then they're all going to lose money along that whole healthcare continuum. So it would behoove them to refer their patients to you upon discharge for a very safe discharge home. And that's something that's not going to cost them anything, but it's going to save them money. It's not going to cost them because the patient private pays for these home care services. Additionally, we look at our email marketing campaigns. So many of our pharmacy owners have their client database, and those clients can become part of their email campaigns that we at Happier at Home manage for them. So when I go on to our Fox News channel speaking about home-related, caregiver-related issues every Monday, those videos are then sent out to your patients. So then they're educating. You're staying in front of your audience and your clients, and you're educating them. You're not just out there saying, hey, start using us, but you're actually providing value and hoping that you're developing that reputation and quality care reputation for them. Additionally, of course, there's social media marketing, which I have to say Thomas is awesome at. He's incredible, makes educational videos, TikTok videos, things that are quick, informational, and people can use. But he's staying in front of people all of the time. So we have this roadmap for our franchisees, and we have our coach that meets with our franchisees to make sure they're doing those things. And maybe they get tied up and forget about one part of the marketing. And so we just make sure that we're keeping them on that road to stay in front of everyone and really utilizing their great reputation that they've developed within the community through their pharmacy.
Thank you so much. We have burned through this time together so quickly. I wish I had another hour to spend with all of you. This has been absolutely incredible. I want to let the listeners know that that if you reach out to RxSafe, rxsafe.com, even if you're not an RxSafe client or customer, they have access to give you all the pieces of the puzzle and the connections for Susan, for Paul, for Rana, for even talking with Thomas. Debbie is included in this mixture and this blueprint. You're going to be at different stages, and when you're going to launch this, how you're going to launch this, understand you're not alone. Please reach out to the NCPA. If you're not a member of the NCPA, make it a commitment to change your pharmacy's trajectory and thrive in 2024 by becoming an NCPA member. This last question does come from our audience. I'm going to ask this of Rana. We know that CMS is going through due diligence to determine and to verify, continuing expansion of long-term care at home services and reimbursement. Let's talk about some of the private organizations, Humana, some of the commercial insurance providers. What can you tell our listeners, and if there's going to be reimbursement in the future for more long-term care at home services?
Yeah, and I know Paul alluded to Express Scripts and Optum earlier. There are some, Part D plans / PBMs out there who do recognize the importance of these services. There are others who have yet to do so, to pay to that higher, rate. So it is definitely a work in progress. There's a lot of conversations going on between partners such as Susan and the plans and the PBMs to keep educating them. It's all about education, right? And then through our alliance, we're working very hard with CMS to make sure that they could add this to the list of patients who have to receive that. They could add at-home patients to the list of patients who have to receive that higher level of care through access standards that exist today. So it's definitely an ongoing effort. We think this administration is very keen on making sure patients age in a place of choice. So I think this is a wonderful opportunity, and we're going to continue working at it. So education is key.
Well, once again, I want to thank you so much for participating. Susan, it's so good to talk to you again. Debbie, as always, and being part of this network.
Thank you.
Some amazing things. Paul, we're never going to let you off the hook. I'm going to keep bringing you back to the pods and talking more about expanding long-term care services. Rana, thank you so much for what you do, and a shout out to the NCPA. And Thomas, like I said, the guinea pig of the group, and it's working. So it's a celebration today that what you have built is working, is going to take you into 2024 to be a thriving independent community pharmacy. So I want to thank you all.
Thank you so much.
Thanks a lot, Todd.
And for more information, please go to RxSafe.com. Once again, that is RxSafe.com. A shout out to the RxSafe team for putting together this webinar as well as this podcast. We wish you a happy holiday season, as well as a very happy and thrusting us into some amazing success for 2024. Reach out to any of us on this webinar for more additional help. And you can always find me at Publisher. That's Publisher at pharmacypodcast.com or pharmacypodcast.com. Thank you so much for listening, and we'll talk to you next time.